Good morning, sir. Good morning.
हेलो
ये तो
हेलो
अटेंडेंस का मस्टर होता है ना, वैसा हो गया.
हेलो
Sir.
Major. Okay, there are
Maithili, good morning.
you can see a lot of videos on there.
Sir, I'll just take care. You just start with the meeting. I'll take care.
Yeah, so just switch off all the videos.
Sure, sir.
And keep everybody mute for some time. Okay, so good morning to all of you, all the members of the ISSP. In the span of 10 days, and the previous ones were very successful, and there was a lot of praises for all those panel discussions. That was a very practical topic last time. What we covered is the COVID situation. There were so many things which came out of that, and this is our third panel discussion. So these are some of the rules, and first, before we start, I must thank to all the moderators and the panelists, because we just gave them 2 days of notice. That's it. In 2 days, they have prepared this panel discussion, because we had some problem with the panel discussion which we were planning on Sunday. So we couldn't do that. So we just requested these people, and they agreed for this thing, and they prepared in just 2 days of time. So I must congratulate to all of them, and thank to all of them. So these are some of the rules of this thing, this panel discussion, online panel discussion. We are keeping everybody mute. Let me repeat this thing. We are keeping everybody mute except the panelist and the moderator, and myself and Dr. Kailash Kothari, the president of ISSP. We are there, our videos and our mic is on. Rest, everybody is on mute. I understand that there are so many senior people who are sitting over there. It is nothing to do with that seniority or juniority. So we are just keeping this mute everybody, so that there is no disturbance in the meeting, because there are so many background noises also start coming from there, and it becomes difficult, because this is one of the limitation of the online platform. Okay, whenever you have any question, I will say don't raise your hand. We written it a raise hand, but don't do that. We have seen that it doesn't work. The best way, if you have any question or if you have any suggestion, you have a chat box here. Please go to the chat box, write down whatever you want to write. You want to write some suggestion, if you want to write down some comment, or if you want to ask some question, you can write down there. Myself and Dr. Kailash Kothari are there. We are looking out to all those chat boxes, and we are taking the relevant comments and the questions, because this also we have noticed that there are so many irrelevant questions also comes into that, which is not related to this topic. I'm not saying irrelevant, but not related to this topic. So we had to see that also, and we'll be taking your cases, your questions and also comments to the moderator, and we'll convey it to all the participants of this webinar. Okay, so another thing is CME certificate. CME certificate. I know there are so many queries coming up. The problem which happened is that people, like in the last panel discussion, we had around 255 participants, but we received around 300-400 plus forms. So we had to segregate all those things also. So that is why it is taking a lot of time. Otherwise, we have everything ready, but we have to see who actually has participated in the panel discussion. So that is taking time. So please bear with us. This may take some time, because this was not anticipated. So that's why it's taking time. We are working on it. You will get within maybe in the next 10 days, you will get your certificates. Whosoever has attended, whichever one. Okay, so please bear with us. Okay, so I'll introduce you with our moderator. Karthik Babu Natarajan is our moderator for this panel discussion. Our panelists are Dr. Pratibha Mache, Dr. Preeti Joshi, Dr. Maithili, Dr. Jitendra Jain, Dr. Ashish Chakravarti, and Dr. Richika Sood. So these are our panelists, and Karthik is going to moderate. Now I'll request our president of ISSP, Dr. Kailash Kothari, to say a few words. Over to Dr. Kailash.
Good morning, Pankaj, and welcome everyone here for very common condition, neuropathic pain, facial pain, on which we are going to have very good panel discussion. Dr. Karthik, he is going to moderate the session, and I wish everyone best of luck. Pankaj, please, you can start the meeting.
Okay, so Karthik.
Yeah, good morning.
I am making you the host, chief host there. Okay, Now you have a control.
Okay.
You have a control.
Okay.
Okay. So now I think we can start with the panel discussion. So Karthik will explain to you how we'll go about this panel discussion. Over to Karthik.
Right. Good morning, everybody. So from the attendance, I can see that lots of people are here. So first of all, thanks to the ISSP, the President Kailasha, Secretary Surange, to take up the initiative and do this webinar. So I do see that last time there was a huge response and a lot of people benefited from it. So we'll have to keep up the good work. So good job from the ISSP. So today our job is to discuss on orofacial pain. Now, as a pain physician, we do see this very commonly in our clinics. So we do see a lot of orofacial pain patients in our clinic. So we have 6 senior esteemed faculty members. They're all reputed and they do a lot of good clinical work. So I'm fortunate to have 6 senior people with me. And also, since it's orofacial pain, I'm really happy that we have 2 people who are basically dental surgeons who specialize in facial pain. So as a pain physician, we do know that the majority of the audience is pain physicians, and we know what are the pain conditions that we treat, but always we do struggle when we see patients with dental aspect. So it's good that we have 2 senior guys who are actually facial pain experts. So they will be starting up the proceedings first, followed by the pain physicians. So the sequence of the talk is going to be, I've divided this into about 6 topics.
Karthik,
and yeah.
Can you go to this presentation mode?
Sorry.
Yeah, perfect.
So yeah, so the sequence of the talk is going to be first we'll finish off with dental pain. So temporomandibular joint would be done by Dr. Ruchika Sodh. She'll be starting off first. Then we'll go to the other dental pains, burning mouth syndrome, again done by a senior facial pain expert, Dr. Maithili Kalatke. Then we'll come to trigeminal neuralgia, atypical facial pain, spinopalatine. Dr. Preeti Joshi has also promised me that she will touch upon cluster headache, even though it falls on headaches a little bit. Then we'll go on to glossopharyngeal neuralgia by Dr. Jitendra Jain, and we'll finish off with oral cancer by Dr. Ashish Chakravarti. Now, obviously, these are big topics. We won't be able to cover them completely in detail. So we'll be telling you, see, we are all clinicians and we would concentrate on how do we see these patients day in and day out in our clinic. So forget about the anatomy and the theory aspect of it. We would be concentrating on how do you actually approach these patients? How do you clinically confirm the diagnosis? And how do you manage them conservatively and surgically? So that would be the focus of the talk. So I would start off with the first one. For the sake and for the benefit of the audience, I've actually encouraged the speakers to get basic. I've given them the topics 2 days ago, and I've actually encouraged them to make basic PowerPoints on these topics. So all of them have some basic PowerPoints. So they would have about 5 or 6 slides to explain it. So I thought this would reach the audience a little bit better. So you sort of have visual and you also hear the speaker. So the doubts, like Pankaj said, put it up in your comment session. We'll come to it at the end of the talk. Okay, so first I would like to invite Dr. Ruchika Sodh, temporomandibular joint pain.
Good morning, everyone. Am I audible? Yeah? Okay.
Yeah.
All right, so let's begin with the today's talk. Thanks a lot, ISSP, for this opportunity, and thanks a lot for all of you who are here to share your Sunday morning with us. So temporo, can I control the movement of the slides, Dr. Karthik?
Yeah,
no.
yeah.
Just see if you can open your slide. Just share your screen and put it there.
Share my screen?
So you have presentation open there on your screen?
Oh.
I think let Karthik only do it. You can just say next slide or something.
Can you see your slides?
Okay.
Just give me, it will just take 1 minute, but I think it will go much more smoothly if I can control the slides. Yes. Okay.
Got it?
Good.
Now you go to share screen. Can you see
I
that
did.
green arrow? Huh?
Yep, I did.
On the right side, if you see there's a small, but yeah.
I did. I
Yeah.
did.
Yeah,
I did.
it has
Okay.
come. Yes.
Perfect. Now you go to presentation mode. Presentation mode, yeah.
Slideshow.
Right. Yeah, this one. Yeah.
All right. So, all right. So we definitely invoke the blessings of the Almighty, and then why is it not moving? Okay. Begin with thank you to my teachers and my close friends who helped me get this knowledge. My topic is temporomandibular disorders. When we talk about orofacial pain, these are the four broad aspects when we see the complaint of the patient, and we try to classify it into these four aspects. And temporomandibular disorders is what we are going to focus on today. And this basically encompasses both the muscular problems and the arthralgic problems around the temporomandibular joint. What are the common symptoms with which the patients come? There are plethora of these symptoms, but three common things that we will notice in the chief complaint of the patient is the gait of the joint, how is the movement of the joint, the sounds that are coming from the joint, and what is the range of motion of the joint. So we know what kind of work we need to do to restore the function of the joint. And there are a lot of systemic problems, metabolic problems, endocrine problems, autoimmune disorders, which will manifest as temporomandibular joint disorder problems. And it is seen very commonly with the increased incidence of fibromyalgia, that typically in the deep masseter, they will develop the tender points, and these can also mimic as temporomandibular joint pain. So there is a strong overlay there that we need to work with the differential diagnosis of the patient. Dizziness and vertigo, or something like a Meniere's disease, that also I see very commonly, that patients have a diagnosis of a Meniere's disease or vertigo, but that would be some crosstalk happening between sternocleidomastoid as a muscle and temporomandibular joint as an apparatus. So we need to understand the patient's symptoms and go backwards and work to decipher what the problem may be. And what are the guidelines that help us decipher and come to a diagnosis? These are the guidelines which have been laid by the RDC TMD guidelines. And I would take a minute here to say that the dentists who specialize with orofacial pain, we have a perspective to look at pain from non-odontogenic perspective. See, when we look at facial pain, we look at it in two categories: odontogenic, one which has dental origin, and non-odontogenic, which is of non-dental origin. And orofacial pain people are trained with the trigeminal system to have a perspective of non-odontogenic pain. So odontogenic pain can very well be taken care of by the general dental and other specialties of dentistry. So IDC TMD are the guidelines which have been laid to come to the diagnosis of the temporomandibular joint disorders. These documents are freely available to read online. And what are these guidelines like? These are guidelines like this. See, for example, temporomandibular joint, when we look at joint, it's just a joint like knee joint, right? So it could be an issue with the cartilage, it could be an issue with the disc, it could be degenerative disease, it could be an autoimmune disease. So there are guidelines laid for each one of them, how to diagnose them. If there is a disc displacement, if the patient has come with limited jaw opening, and we say anything up till 25 millimeter, when the function is there, we go with non-interventional mode of treatment for patients. So disc displacement without reduction is a diagnosis, when common complaint would be limited joint opening in terms of the opening range of motion. In terms of the sounds, we may be having an opening click audible, but not the closing click when we are looking at the sounds. And in terms of the gait of the joint, we will see deflection of the joint happening onto the affected side when we are seeing these patients. Now, what is the validated imaging for this MRI criteria? And these are again completely laid down in these documents. Then when we are looking at RDC TMD guidelines, we take care of both the axes. There are two axes to look at it, axis 1 and axis 2. Axis 1 takes care of the physical diagnosis, and axis 2 takes care of the psychosocial status of the patient. So how is it related? Maybe we can have some case discussions, and I can elaborate on that better. But we know today by the research work which is on that it is not only the spinothalamic tract which plays a role in the pain management, but also there is a significant role which is played by the insular cortex region or the anterior cingulate region. Where is the input coming from for these regions? We know that the C fibers are polymodal in nature, and we have metaboreceptors there, we have mechanoreceptors there, and we also have extreme sensitivity to certain psychological states with these receptors. So emotional states bring about change in the neurochemical soup, and this brings upon the difference in the conduction with the C fibers, and this eventually reaches the insular cortex. So through the interoceptive pathways, we have a lot of crosstalk happening at the trigeminal nucleus. So we have to go backwards in the patient's history and integrate all the elements. All these guidelines are very well laid in these criteria. So where is the treatment beginning? Treatment begins with the understanding. We can develop a right treatment strategy only if we know what is to be done. So education about orofacial pain is the most significant thing. When we say about joint, we can say that it is arthralgic and myalgic pain, both. Arthralgic pain, I think everybody knows how to deal with the knee joint, much more experience there. And when we talk about the myalgic pain, we see that if we know that in the upper quarter, trigger points are more complicated as compared to the spinal system. Why is it so? Because in the upper quarter, what works as a mechanism of pain physiology is convergence. And also the way the interneurons talk is a little different in this part. But so going with the convergence, if we have a trigger point in deep masseter, that could be felt as a temporomandibular joint pain. Now, if this is a trigger point with referral pattern and we can clinically reproduce it, our line of treatment would be trigger point injection for this patient and break the pain cycle. If we find a palpable trigger point there, which is occasionally referring the pain, maybe we will go with a lesser modality like laser therapy, photobiomodulation, or other physical therapy modalities. It may be a trigger point in digastric muscle, which is felt around the joint area as pain, and we may mistake is as pain coming from the stylomandibular ligament or pterygomasseteric sling. So we have to understand from reproduce the pain before we proceed with the treatment. And if we know that the pain source is somewhere else, and the site of the pain is somewhere else. So if this is the source of pain and this is the site of pain, the trigger point has to be done at the right place at the source of pain to treat the patient appropriately. Then we also see a type of TMJ headache, which is a part of IHS classification of headaches. But why is it important to know whether this pain is coming from the muscular elements or if this is a type of TMJ headache? Because then again, the treatment modality will change accordingly. We will make a different type of appliances for these patients. So we treat a lot of these patients by intraoral appliances. So the type of appliances that we make for these patients is different. I'll just take 2 minutes to show a case here. This is what is called as OPG, where we see all the oral structures in one film. And these are the temporomandibular joints, which are visible. And you can see here that on the left side, the joint is coming a little below in the articular eminence, and the condyle is more posteriorly placed on the right side. And this is to see the movement of the joint, the opening and the closing film of the same patient. The chief complaint of this patient when he came in was difficulty to eat properly, so that he could not occlude his teeth properly and get the right bite. That was his problem. But this was not enough. This OPG is diagnostic, was not enough. You suspect a lesion there and go ahead and do a detailed CBCT, which is focused CT scan for the for the facial part of the body. And we saw the destructive lytic lesions here and irregular margins. And this was a case of multiple myeloma. So if we could, we would have started the treatment for this case without establishing the complete diagnosis. It would not be good for this patient because we could create the advancement of the disease on those conditions. So treatment of temporomandibular joint is like all other joints, subjected to various kind of injuries. An accurate diagnosis is extremely significant for arriving at a conclusion. My thanks to all my teachers, my family, my students, my friends and colleagues. Okay, so I will stop sharing my screen, Dr. Nitraj.
Yeah. Thank you. So that is the dental surgeon's perspective of how to manage temporomandibular joint pain. So she talked about the bony aspect of it and the muscle aspect of it. And we have to basically, from the pain pattern, identify which muscle is getting involved, and then consider the conservative management, which includes physiotherapy modalities like laser and stuff like that. Just one question before we go to the next speaker. As a dental surgeon, in terms of interventions in TM joint pain, is there anything else we can throw light on?
There is, like I said, that if there is opening which is less than 25 millimeter, we do consider intervention. Interventions would be treatment, surgical, like if there is an ankylosis. If there are developmental disorders for the joint, then definitely there are TMJ surgeries which are required. If it is the intracapsular disorder and we see that the secretory fibers are involved and that there is a comorbidity with the salivary gland disease, then auriculotemporal nerve block is also recommended for those conditions. So it depends actually on the pathology, but the percentage of patients which need intervention for temporomandibular joint disorders is very, very minimal. In fact, in between 70s and 80s, there is a lot of research which was done in United States on this aspect to study what is the right approach to treat the temporomandibular joint. And it established that until and unless the opening goes below 25 millimeter, we do not recommend intervention.
Right.
Okay, there is some questions from the audience. Can we take questions, Karthik?
Yes. I think we should take the question here.
Okay,
So,
go ahead.
Dr. Murthy is asking, can you highlight the recent advances in the diagnostic aid? Ruchika.
The recent advances we have, see, the last website of RDC TMD was updated was 2nd of March. So all the advances which have been made or are done are listed on that website.
Okay, so another question is that how to differentiate it from TM joint necrosis, osteonecrosis? Clinically.
The quality of pain. The quality of pain will be completely different. The osteonecrosis pain, you will not get a break from the pain. And then secondly, also in the osteonecrosis, you will get a moth appearance on the radiograph of the patient, which you would not get in the joint otherwise. And osteonecrosis mostly will be more in the mandible, right, rather than focused on the joint. So it would be more of a referred pain on the joint rather than the...
Usually the osteonecrosis is of mandible.
Yeah.
So any role of PRP in TM joint arthritis?
Yes, I would let Dr. Kothari take that question because he is the one clinically doing more of that work. There is a role of PRP. It is extremely studied and the research is very equivocal about the role of prolotherapy or PRP when the temporomandibular joint disease is concerned. So clinically, personally, I am getting beautiful results by mixing a couple of non-interventional therapies and intraoral appliance therapy. So PRP, yes, breaks the pain for 2 months, 3 months for some patients. But I see that patients come to me after getting PRP done.
Okay.
So I personally do not have a lot of experience with that treatment modality. I do not do a lot of it.
Okay, there's a comment from Dr. Lakshmi Vas. She's saying the mouth opening is determined by the spasm of the mouth closure like temporal and masseter, and diagnosis of this muscle would improve the trismus.
Which is very, very true. Myospasm can also affect the mouth opening. But then that is also a part of TMD. When we talk about TMJ disorders, we talk about myalgic component or the arthralgic component. So that is taken care of in the myalgic component, which is true. So we do address the masseter and temporalis from the appliances and all of that.
Right.
Dr.
For,
Rajat,
for
I'm asking,
yeah.
what is the role of bruxism in the cause of the TMJ disorders? Bruxism.
So, firstly, I think also that if it is a muscle spasm, then spray and stretch is also a good therapy to approach with clinically to check it out at how much of release we are getting by releasing the spasm. And coming to bruxism, bruxism is a neurological disorder. And depending upon what stage of sleep you are actually grinding your teeth and bruxism is happening, its significance is decided. So the aim of treatment in bruxism is to protect the teeth
Okay.
and manage
How
the
much is
sleep. It
the
will go more with the sleep medicine. So
Any role of
understand what stage of sleep the patient is bruxing, and then if it is delta sleep, more with the mindfulness and those kind of activities. And actually the fMRI studies show that the area of brain that lights up with bruxism is around the insular cortex. So we should approach it through those tracks.
any role of botulinum toxin in this?
Yes, very much. Botulinum toxin is used for the pain management of facial pain very commonly. And we don't know yet why and how Botox works in the facial pain. I think half the globe is trying to figure that out. But knowing that if it is recalcitrant pain and nothing else is working, Botox injections are given. About 10 units per area of the muscle, and the patients find pain relief. And also for when it is about the mixed pain in the temporomandibular joint, the EEG guided Botox injections with a lateral pterygoid have also given very good results.
Okay.
Okay. So if you find myofascial component or the muscle being involved, one of the surrounding muscles because of TMJ, how would you actually approach it? So first is conservative. If you're going to the next step in terms of intervention, which sequence and what would you do first?
Muscle component would be the referred pain from the trigger point. So identify which muscle is contributing to that pain and block that with the appropriate trigger point injection. If it is a masseter or a digastric or trapezius, which muscle is contributing to it, and give it with do the trigger point injection.
So you're saying first go with a 1% lignocaine injection and then maybe if required a botulinum toxin injection.
Yeah, Botox would be a therapy in itself. So we would go with the trigger point injection, and Botox I think should be reserved for more for recalcitrant pain and where nothing else is working. There are a lot of things which work for TMJ pain, and I think the enigma around TMD is more because of the path of a process of differential diagnosis, or because of pain physiology links not being established. See, we are going towards mechanism-based pain management today. So once we complete that curve, I think the enigma around TMD will really resolve. Botox is required for a very, very small percentage of patients. Maybe 3 or 4 cases in a year go for that.
I think Ruchika, we are working together for so many years, and I have seen so many patients with trigeminal neuralgia who's coming to me as a referral, and we find that it is not a very classical pain of trigeminal neuralgia. And when we discuss and when you see all these patients, we find out that there are a lot of other causes which are causing pain rather than trigeminal neuralgia. So it is very common to have trigeminal neuralgia like pain which is coming from other structures like TM joint or muscles or some other maybe cervicogenic headache can also produce facial pain. So this is very important to look after the causes which are different from trigeminal nerve, which can produce pain similarly like trigeminal neuralgia.
Which is very true. So if the motor component starts getting involved and the secremotor function is also getting involved, that is when the pain becomes very severe. or see, we have cranial nerve 7, we have cranial nerve 9, and when I talk about the interoceptive pathways, we also look at the fact that these pathways are the balance of the autonomic nervous system and the parasympathetic system. So the crosstalk happening between the sensory neurons and the input coming from the ANS, and what is making the intensity and severity of this pain much more. And usually by the time patients come to Pain Clinic of India, they have exhausted a lot of other options and reached us. So every surgery has also created a neuropathy because of sustained inflammation state. So we look at it as a trigeminal neuropathy condition rather than as a neuralgic pain. Now, how does a clinician differentiate that? The differentiation is with the refractory period. If it is a classic trigeminal neuralgia case, there is going to be refractory period for that patient. These patients who have continuous pain, sustained pain, maybe we will not have a refractory period, and there is a possibility of MPDS going very bad, having autonomic system involved and tearing of the eyes happening for these patients. This should not be confused with neuralgia. Yeah. So we treat them with the modalities of trigeminal neuropathy, and I think that will be covered in the subsequent slide presentations.
I think we can move.
Yeah, thank you, Dr. Ruchika. Fantastic lecture. Thank you. Next, I would like to invite Dr. Maithili. Dr. Maithili Kalatka. She's a dental surgeon. She does facial pain as a serious practice. So she's going to be talking about other dental pains and oral painful conditions. So Dr. Maithili, if you're ready.
Yes. Good morning, everyone. So should I start the share screen from my end?
Yeah, please.
Okay. Am I audible to everyone, and is my screen visible?
Yes, we can see your screen.
Okay.
So just share the present. Yeah, good. Yes.
Good morning, everyone. At the onset, I'd like to thank Dr. Kailash Kotari and ISSP for taking up this wonderful initiative and providing us this platform here today. It's a wonderful panel discussion that we're going to have. So today I'll be speaking on dental pain and burning mouth syndrome. So when we speak of orofacial pain, about 80% of the cases of orofacial pain are basically dental in origin. And when I say dental, it includes both soft tissues and hard tissues of the oral cavity and the head and the neck as well. The most common cause is the tooth and the surrounding soft tissues in the oral cavity. And when I say this, what's very important that we recollect and remember is that in the face, the referral pattern is of an onion peel appearance. So your maxillary and mandibular molars, the maxillary and the mandibular incisors, the canines and the premolars can refer pain to each other. So when I say this, what I mean is that if there's a deep cavity or an abscess in the mandibular molar, the patient may feel it in his upper jaw. So it's very, very essential that any patient that comes into a practice with a complaint of orofacial pain, we do give a thorough dental checkup. And it's not that you have to seat him in a dental chair and have the high-tech lighting. You could even do this with the flashlight of your mobile sitting on a regular chair as well. So when we speak about dental pain, the two most common conditions are, one is the superficial somatic pain, which basically affects your soft tissues, such as your buccal mucosa, your lips, your tongue. And in these structures, most of the causes are very evident when you look into the oral cavity. So having a good source of light is extremely important, and it's very essential that you do a thorough dental checkup and look at all the structures in a sequence so that you don't miss out anything. So the characteristic of pain in this condition is that it's bright and very stimulating. And once you treat the cause, it resolves by itself. So if you have an aphthous ulcer, for example, and you see that it's being caused due to some sort of denture irritation or due to a sharp tooth, you either trim the tooth or you trim the denture, and then the aphthous ulcer may resolve. In contrast to this, you have the deep somatic pain, which is basically pain due to the tooth or the structures which are holding the tooth. So you have periodontal ligament, which is a musculoskeletal structure which holds the tooth in place, and it binds it to the gingiva and the bone. So in deep somatic pain, when we speak about tooth pain, the characteristic is that there is a all or none response. So meaning if I have a mouth mirror and I percuss or tap on the tooth, either the patient has pain or he will have no pain. There's no graded response. So it is either all or none response. And even looking at the tooth intraorally, many times you will see caries on the occlusal surface of the tooth, which is very deep, and you may have abscess in the gingiva below the tooth. So the second kind of pain that we're talking about is the periodontal ligament pain. And in this instance, it is a graded kind of response that you get. So if I percuss harder with a probe or a mouth mirror, there's more pain. So in addition, this pain may also refer, like we spoke about in the onion peel pattern of reference. In addition, a common condition that we also see is due to the impacted wisdom tooth. I'm sure a lot of you would have visited dentists for your impacted wisdom tooth. So what happens is that there is the gingiva which covers the tooth, and there could be food accumulation below this gingiva, and that causes inflammation, and that could also lead to pain, which behaves like periodontal ligament pain. So when we speak about dental pain, the most common condition that we see, which is very similar to dental pain, is the post-traumatic trigeminal neuropathy or persistent dentoalveolar pain. These used to be called atypical odontalgia a long time back, and they've been renamed currently. So basically in dental pain, the main criteria for differentiation is that in persistent post-traumatic dental neuropathy, what we see is that the pain does not remain the same for 3 months. So for PTTN or PDAP, the diagnostic criteria is the pain should remain the same in the oral cavity or the structures around the tooth for a minimum period of 3 months. And why they've taken that period of 3 months is that no dental pain stays the same for 3 months. It either goes into an acute phase where it becomes, where there is swelling, extraoral swelling, or it goes into a quiescent phase with either granuloma or cyst formation. So persistent pain of the same quality for 3 months should alert the physician towards a PTTN or a PDAP. In most dental pains, the source of pain is obvious on clinical examination or on radiographs. So even if there is a cavity between the tooth structures, on a radiograph, it would be clearly visible. So if a clinical exam and if a radiographic exam is negative for dental pathology, it should again alert the physician towards a PTTN or a PDAP. A very interesting and useful chairside tool is your local anesthetic block. And what we do is we routinely use intraoral blocks or infiltrations around the area where the patient complains of pain. So if the source of pain is not visible, we just do a local infiltration or a block with lignocaine. And if it blocks the pain completely, it suggests that it is more of a dental pathology. In PTTN or PDAP, this is equivocal, meaning the patient will say the pain is relieved partially, but is not still completely gone. So when we speak about dental pain, and the guidelines by the AAOP and all organizations is that when you see dental pain and you have confusion whether it could be an associated another condition as well in association with the dental pain, you would always treat the dental pain first. And the line of treatment for treating dental pain is either root canal treatment or different periodontal procedures for the gingiva and the gums. A lot of antibiotics and analgesics are also used to provide relief from dental pain. Now in PTT and PDAP, on the other hand, it is treated like a neuropathic pain condition, and we follow the guidelines of NUPSIG. The second condition that we'll be speaking on today is burning mouth. And when I hear burning mouth, a lot of healthcare professionals tend to commonly use the term burning mouth syndrome. So the first thing we need to know is that we need to differentiate burning mouth syndrome from burning mouth. So when we say burning mouth syndrome, it is a primary disorder by itself, and it doesn't have any specific etiological cause. Current thinking is that it is a neuropathic pain disorder, and they may be hypofunction of the chorda tympani nerve, and the lingual nerve is unleashed, causing burning sensation. So the ISSP currently defines burning mouth syndrome as chronic intraoral burning sensation without specific etiological causes, either local or systemic. So this is primarily manifest as burning in any region of the oral cavity. It could be, it's most commonly seen in the tongue and the palate, but it could involve any region of the oral cavity, including the gingiva and the buccal or lingual mucosa. It's most commonly seen in middle-aged females between 50 to 60, and it's more in the evening. And when the patient wakes up, classically they say that the pain is very less in the morning when they wake up. It's also associated with taste changes and perception of feeling of dryness. So a lot of patients complain of bitter taste in their mouth when they have this condition. A very characteristic thing that the patients report is also reduction with sweet taste. So why is this reduction with sweet taste seen? Is that it activates the chorda tympani, and because of that there is a sort of balance because of which they may feel temporary relief in their burning symptoms. A classic thing again here is a local anesthetic, and we often use topical local anesthetics, and in this case again the burning is either equivocal or it commonly gets aggravated. Now the second thing is the secondary burning mouth or burning mouth due to specific etiological causes. And in this condition, you have either nutritional deficiency, you could have systemic conditions like diabetes. It could also be subsequent to a lot of medications. It could be subsequent to allergies of denture materials that we use intraorally, or it could be allergies to different filling materials that we see. Or it could be secondary to systemic conditions like lichen planus also. So in this condition, like I mentioned before, it has a sharp stimulating quality, and the cause is usually evident with blood work or clinical examination and your history. And classic thing is that secondary burning mouth completely reduces with a local anesthetic application on the region. So treatment for both these modalities is completely different. So when you see a patient with burning mouth, the first thing is that you would exclude the local and systemic causes. So you would start with a complete local examination, a complete history, and your lab tests to rule out secondary causes as well. Now, once you find out these causes, the protocol is that you will treat these causes first and then watch to see if there is resolution of pain. So in primary burning mouth syndrome, once the patient is recognized not to have any etiological, systemic or local factors, then you would treat it like a neuropathic pain condition. And commonly what we use, which is found to be very, very efficacious, is clonazepam. We use it both in the topical form and we use it in the systemic form as well. Alpha lipoic acid has been found to be moderately beneficial in these patients, especially in combination with gabapentin. And we also use psychotherapy in these patients. So systematic analysis which was done found these three to be most effective in treating burning mouth syndrome. Again, getting 100% relief is a difficult issue in many instances, but we are pretty much successful in reducing the pain by 60 to 80% in most of the cases. Again, capsaicin has been found to be moderately efficacious, but again, most of the patients do not tolerate it intraorally, and hence we are limited in its usage. So like I mentioned before, you need to, when a patient presents with burning mouth, the first thing that you would look for is local and systemic etiological factors, and that you would do through a clinical examination, your history, and with your lab tests. And once you resolve those, then you would treat it like a idiopathic or primary burning mouth syndrome. I'd like to thank ISSP for providing us this platform to express our views. Thank you.
Thank you, ma'am. So probably the take home for the pain physicians is that we need to work in conjunction with the dentist to sort out oral and dental issues. Yeah. Just to start off the discussion, in terms of treating these patients with medication, how happy are these patients with the anti-neuropathic pain medication?
Most of them are pretty happy. Again, we would start off with a low dose and again titrate them up. Most of our personal favorites is clonazepam. Again, we use them as wafers where we keep them on the tongue and ask them just to swish and spit a couple of times a day. And a group from Europe has found that there are peripheral GABA receptors. So with minimum side effects, we are able to control their pain pretty well in a lot of patients. Some patients who do not find it very efficacious, we do add systemic clonazepam and then move on to gabapentin. We do avoid tricyclics mainly because of its anticholinergic effects, because the patients, most of them have a feeling of dry mouth as it is. So we don't like to compound that. But most of them, like I said, we do manage to get 60 to 80% relief in most of the cases, once the local and systemic factors have been addressed.
And
So Maithili, okay. Yeah, Karthik.
Yeah, sorry. And other than the psychological support and anti-neuropathic pain medication, is there anything else in terms of treatment that we can offer?
Burning mouth, as of now, these are the main modalities of treatment. We treat the local and the systemic causes. So many of the patients do have a conjunction of multiple local and systemic causes when they're present. So they would have antidiuretic medications which causes a feeling of dry mouth. They would have candidiasis, and a lot of them are diabetic. So treatment of all these causes is extremely important, and there could be dental causes as well, like allergies to dental materials which are causing lichen planus like reactions, lichenoid reactions. So treating those is also extremely important.
Right.
Can we take some questions here?
Yeah.
Sure, sir.
The panelists from the audience. Okay, so Dr. Renika Pai is asking, is there any, do you have any experience of managing post-stroke patients with burning mouth? And the second part of the question is, what medications may cause burning mouth?
Sir, could you please repeat the first part of the question?
Any experience of managing post-stroke patients with burning mouth?
Again, we think this is a part, I personally do not have experience, but what is available in literature, It is again a manifestation of the neuropathic pain disorder. It is a part of the post-stroke spectrum that we see. Again, the management is the neuropathic pain NUPSIC guidelines that we follow. But among all of these, clonazepam would be the go-to medication unless there is medical contraindication for the use of it.
And what medications can cause burning mouth? Is there any?
A lot of antihypertensives cause burning mouth. Post chemotherapy, chemotherapeutic agents, especially vincristine, these are known to cause neuropathic pain and burning mouth as well. So screening of a lot of anticholinergic medications also contribute to feeling of dry mouth in a lot of patients. So screening for the medical history is extremely important.
That's why we avoid these all antidepressant drugs for management of neuropathy in these patients.
Yes.
Any specific nutritional deficiency which may cause burning mouth?
Iron deficiency anemia is known to cause. B12 deficiency is also known to cause. So when we are screening our patients, we do commonly order the thyroid panel, we order the CBC. So these are, the basic tests that we do order in these patients to rule out nutritional deficiencies and systemic causes.
So there is one patient scenario from Dr. Sunita. She got a patient with severe burning pain on lateral aspect of the tongue. There is no significant history except dental extraction.
Yes, this is what I was referring to as PTTN or PDAP. So this is the current terminology that we are using. A lot of people prefer to use the term atypical odontalgia. A lot of people also refer to it as atypical facial pain, part of the atypical facial pain spectrum. So basically, following any sort of trauma in the peripheral nervous system, it could lead to neuropathic pain changes, and it can manifest as dull, aching, or burning kind of pain, which is constant throughout the day. And again, the ladder that we use for these patients is the neuropathic pain ladder that we prefer in this patient.
Any role of lozenges or this thing, local anesthetic lozenges or something?
Pardon, sir?
Any role of some local anesthetic lozenges we have? Is there any of that?
So commonly
over there.
In post-traumatic trigeminal neuropathy, sometimes after a period of time, there is central sensitization and there are autonomic changes. And in these instances, we would refer the patient and it may progress on to CRPS in the orofacial region. And in these subset of patients, we do refer for the stellate ganglion block.
Maithili, is a local application of clonazepam is available, or if it is not available, how do you use it?
So it's the same wafer that we get. Patient just places it on their tongue. It will melt, and the patient just keeps it in their mouth for as long as possible, swishes it, and spits it out. So we ask the patient to do this at least 3 to 4 times a day. And in severe cases, we start adding systemic clonazepam. In mucositis, though, we've had good relief with something called a magic mouthwash, which we routinely use in the US. In India, what we were doing is we were getting our local pharmacology department to compound them. And this has different things like milk of magnesia. It's a compound of different materials, basically, and that offers temporary relief to a lot of patients.
And what about your ketamine gargle or lignocaine gargle? Is it useful?
Yes, they have found some effects of these in the peripheral receptors. And again, when we were there, a group in the NIH is working on topical opioids as well. And one of the latest things that we are offering in the US is some bioadhesive patch with a local anesthetic, ketamine, ketoprofen, or any material that we think contribute will help these patients. It's available as a topical paste, and they would basically apply it with a sensory stent, which like covers that area and prevents leakage of the topical medication. So, and this particular pharmacy in the US controls the depth of delivery and the type, whether you want it deep penetrating or you want it superficial penetrating. Like if you think it's an instance of neuroma where you want it to be deep penetrating, they make it in a micellar form where it can go to the deeper structures and act. Thus the systemic side effects are avoided. Or even if they need systemic medications, you can use it as at a much lower dose.
Okay, and we have many interventional pain physicians here, and they want to know any role of any intervention specific in burning mouth syndrome. Do you?
She said, I think.
It's very limited, sir. Generally, with
Not
burning
much.
mouth, yes, because we think the chorda tympani and there are a couple of theories in the neuropathic pain spectrum again. One is that they think there is hypofunction of the chorda tympani nerve. And the other is that the peripheral nociceptors are unleashed, and the small unmyelinated fibers, there's hyperfunction. So there are 3 different phenotypes of patients where either the A beta fibers or the A delta fibers may be affected. So it's very hard to provide interventions depending on specific phenotypes. So analyzing these phenotypes, we have still not been able to conclusively say which subset of these patients would respond to which intervention. And generally with interventions, what we have seen is that these patients tend to do worse, or the pain starts migrating and shifting in other areas of the face.
That's
So,
very important.
yes.
So, before you go for intervention.
Right.
Anyway,
Yeah, Karthik, please.
Before we go to next, I will just add one point that Dr. Maithili and Dr. Ruchika Sood, they are full-time orofacial pain physicians, and they don't have much dental practice. So there's a difference when you refer a patient to a dentist who is not practicing orofacial pain, and the ability of them to identify these things is very different from what they can do. They're specially trained into orofacial pain. So you need to understand that. So they are orofacial pain physicians.
Thank you so much, sir. People like you who have been motivating us to continue.
All right. Yeah, Karthik.
Right. Superb. Thank you to both of you. So we'll move on. The next talk is on trigeminal neuralgia. And I would like to invite Dr. Pratibha Mache to start on trigeminal neuralgia. Dr. Pratibha, you ready?
Where is Pratibha? Yes.
So very good morning, and hearty congratulations to Pankaj and Kailash for taking this excellent initiative of the webinar series for the on pain. So shall I share the screen?
Yes.
My screen?
Yes, please.
Yeah, so I'm going to deal with trigeminal neuralgia, and this is, I think, one of the very common conditions that all pain physicians are practicing, or they get into their practice. This is one of the most commonly found neuropathic disorder, which is characterized by the paroxysms of attacks of sudden severe unilateral facial pain in the distribution of one of the trigeminal nerves. So we find this in mostly the elder patients, that is more than 50 years of age. But I have found this trigeminal neuralgia even as young as 22 to 23 years of age. I don't know about other people, how is their incidence, but I think it is migrating even to the younger population. Females have more preponderance, right side is affected more, and the V2, V3 division is the most common involved, and the V1 division is the least involved division. Now there is a very interesting new classification and diagnostic grading system for the trigeminal neuralgia, which is come up by which is brought in that because there was a lot of confusion about the secondary trigeminal neuralgia being not included in the classification. There was no proper nomenclature for that. So that's the reason why they have come up with this grading, wherein if you get a patient where there is a history of unilateral orofacial pain, and it is restricted to the one of the territories of trigeminal neuralgia with the paroxysmal attacks, then definitely, not definitely, but possibly it is of neuropathic nature. Now you take proper history and examination and you find that there is trigger zones, presence of the trigger zones are aggravating the pain. Then definitely it will establish the clinical diagnosis of trigeminal neuralgia. Once you have established the clinical diagnosis, you want to do investigation further and confirm the lesion or the disease. So you are doing MRI, and if the MRI is showing the vascular compression, then it is called as classical trigeminal neuralgia. And if you have some other demonstrable cause, then it is called as secondary trigeminal neuralgia. And suppose you don't find any cause on diagnosis or investigation, then it is called as idiopathic trigeminal neuralgia. So this is the rough classification, that is classical trigeminal neuralgia. When there is an evidence of vascular compression, mainly the superior cerebellar artery and the anterior inferior cerebellar artery. Idiopathic, which is I think most common in our practice, that is an unknown etiology. And secondary trigeminal neuralgia, usually we find it in multiple sclerosis and the CP angle tumors. The brief pathophysiology is because of the vascular compression, there is chronic irritation of the trigeminal nerve at the root entry zone, and this leads to the focal demyelination of the afferent fibers, leading to aberrant discharge, the neural discharge. This causes the attacks of the pain. Now coming to the diagnosis, we all know that the diagnosis of trigeminal neuralgia is mainly the clinical diagnosis. Investigations are just to confirm the secondary, to rule out the secondary or confirm the vascular loop. So how do you diagnose? Like classically, it presents as a sudden severe pain. Most of the times it is described as a shooting type of pain or an electric shock kind of a sensation. Invariably it is unilateral and it is in one or more divisions of trigeminal nerve. It is restricted into those divisions. So it comes in attacks lasting for few seconds to up to 2 minutes, and there is invariably, mostly there is a pain-free interval between attacks, but some of them may have a continuous aching type of pain in the background. And the most important thing here is the presence of trigger zones. So these trigger zones which are present in the ala of nose or the buccal mucosa or the cheek or the vermilion, these mild stimulation or mechanical stimulation of these trigger zones will provoke the pain. So the patient will complain that when I am going on a bike, there is the wind exposure to the wind, when I am sitting in front of the AC, when I'm talking, brushing, chewing, shaving. These are the small things that day in and day out they're doing. They will provoke the activities of provoke the pain attacks. On examination, mostly there is no neurological examination is always normal. And in case you find any abnormality in the neurological examination, you should have high index of suspicion for multiple sclerosis and CP angle tumors. In multiple sclerosis, mostly it is a bilateral in nature. And CP angle tumor, invariably you will have some neuro deficit will be present. So the diagnosis is mainly clinical, but CT, MRI and MR angiography is done to rule out these neurological disorders and the vascular malformations. Now here I want to insist on one thing that we invariably, I think all of us ask for MRI, but MRI of the brain, if there is a vascular compression is there, is it necessary that there is a problem? So they have found out that lot of patients who are asymptomatic, also there is a presence of neurovascular contact. So just the mere presence of neurovascular contact is not sufficient, but you should also look into the degree of neurovascular compression, the morphological features that are happening, that is the displacement of the nerve or the atrophy of the nerve, at what location the neurovascular compression is occurring. That means if it is at the root entry zone entry into the brainstem, the severity of the symptoms will be much more. So it is very important for you to understand the findings of the MRI. Just the neurovascular contact is not enough. I have also seen one of the patient wherein the patient came with the pain into the maxillary division, and the MRI was done, and the MRI showed the opposite side neurovascular compression vessel loop was there on the other side. So when you go into the, when I went back into the details of the history, then I found out that the patient had autonomic symptoms also. So it was not a trigeminal neuralgia, it was a spinopalatine neuralgia, and the spinopalatine ganglion block worked very well for him. So I feel that it is not necessary that always the neurovascular compression, neurovascular loop is there, then it is not necessary that the patient will have symptoms. So you should get into the details of morphological features also. So coming to the differential diagnosis, we have a lot of things, and definitely I think just now Ruchika and Maithili have covered in detail. So there, the diagnosis from the dental point of view, I think makes a lot of importance, because most of the times we as pain physicians are not much aware of the dental pathology or the dental problems which are faced, as well as at the same time the dentists are not aware of these neurological disorders. I have seen a lot of the dentists who refer the patient by after doing the dental procedures, and when in the initial phase of the trigeminal neuralgia, which is also called as a pre-trigeminal neuralgia, the patient will present with the dull aching type of a pain, and they are referred to the dentist, and the dentist will do some dental extraction, and the pain is aggravated, and then it becomes a post-traumatic trigeminal neuropathy, which is explained by Maithili. So we have a lot of conditions. Post-herpetic neuralgia, if you miss out the lesions, then you may have problems. So you should, these are some of the conditions. Glossopharyngeal neuralgia, another confusing condition wherein the pain will be there at the back, is overlapping in these conditions. So coming to the medical management, we all know that carbamazepine is the drug of choice. It is the first line of treatment, but we must keep in mind the adverse effects, because it can cause a lot of dizziness, and many of the patients I have seen that the compliance is not there because of the complications. They'll have so much of dizziness, ataxia, they'll have confusion, that they'll just leave the medication. So you should explain when you're starting the dosage, and since this condition is found mainly in the elderly patient, the problems are more found with the carbamazepine. Oxcarbazepine is one of the better drug, which is equally effective and has a good side effect profile. Phenytoin, gabapentin, baclofen, lamotrigine, and opioids are also found to be effective, but not as a monotherapy, but only in addition to carbamazepine or oxcarbazepine. Botox is coming up, and it has been recently tried with good results with the injection at the trigger zones, and also in patients with hemifacial spasms, in patients with trigeminal neuralgia. IV lidocaine, there is not much of an evidence, but it can be tried as an add-on treatment in refractory trigeminal neuralgia. Now coming to the most interesting part for all the pain physicians, that is interventional pain management. So we have the plethora of management techniques which are available. We have the percutaneous interventions and the surgical techniques. The percutaneous interventions are peripheral nerve blocks, the radiofrequency ablation, which most of us are doing, and glycerol rhizolysis and percutaneous balloon compression. Surgical techniques are done by the neurosurgeon, that is gamma knife, Janeta's procedure, and endoscopic decompression. So now when do you start, or when do you do the interventions? When the medications are ineffective, or when patients not heard?
Go on.
Okay. So when the medications are ineffective, or the patient has intolerable side effects, then you should think that what is appropriate for the patient. If it is a young patient, you always give the choice of surgical treatment to this patient, because he has a long way to go, and RF ablation may not last for that long. And if it is an elderly patient with a lot of comorbidities, and the patient himself is not willing, then you should definitely go for the other percutaneous interventions like peripheral nerve blocks and RF ablation. So peripheral nerve blocks, I think most of our pain physicians, I don't know how much they agree with it, but in my practice, we have used many peripheral nerve blocks. using alcohol, phenol, and glycerol. So glycerol for the Gesserian ganglion. So especially when the patients come with the ophthalmic division, then I always prefer that the supraorbital and supratrochlear nerve blocks, alcohol neurolysis is much better than going for an RF ablation, which has much more significant side effects. And also in patients who are not willing for the RF ablation, or they cannot afford because it is not a cost-effective technique. So patients, I work in an institute and we get law belongs to the low socioeconomic status, and therein I think we can definitely have a role of peripheral nerve blocks for the trigeminal neuralgia. And the definitive treatment is definitely the radiofrequency ablation. Here we do the take a CM. I'm not going to go into the details of the technique, but here we take a submental view and the patient identify the foramen ovale. And once you identify the foramen ovale, depending on which branch you are targeting, so you if for the needle goes in an end-on fashion or the tunnel vision, and for the mandibular, it is the lateral most part. For the maxillary, in the middle part, and for the ophthalmic, it is the medial part of the foramen. Once you get a feeling of entry into the foramen ovale, then you have to turn the C-arm into the lateral view. And once you see in the lateral view, the needle direction should be directing to the angle between the clivus and the petrous part of the temporal bone. And the depth should not be 2 millimeters beyond the plane of the clivus. Now, once you are confirmed with your needle position, then you go for using a 22 gauge 10 centimeter 5 mm active RF needle. You do the sensory and motor testing, and once you are satisfied with the paresthesia along the desired nerve route, you can go ahead with the lesioning with that using the temperature of 60 to 80 degrees centigrade and 3 lesions. Between each lesion, you should check for the corneal reflex. And the most important thing, there are few things here, that is, if there is a traumatic tab, then you should try to change the needle position, relocate the needle. Suppose twice again you are getting the blood tab, then you should abandon the procedure. Second thing is, if you get CSM neurolytic injection, and you can go ahead with your RF ablation. So, and there are another few things which also you might face is that if there is a high impedance, then again you should remember that it is in the non-neural tissue. So these are few things which you should take care while RF ablation. And the most important thing now, there is a lot of people, I hear that people do perform PRF. So there are the RCTs comparing the conventional and PRF has shown no efficacy for the pain relief with the pulse radiofrequency for trigeminal neuralgia. So now we have the balloon compression. Coming to the next intervention, that is balloon decompression. I personally don't do this intervention, but this is one of the good intervention when there is an ophthalmic involvement. And we have compared here these 3 procedures which are commonly done by the pain physicians, wherein we have very good results in terms of efficacy with RF ablation. The relapse rate is also very low and the success rate is very high. So I would definitely say that amongst the 3 procedures, RF ablation is one of the best techniques that should be taken up for the trigeminal neuralgia. But we have to also keep it in mind here, since I have been allotted only, I was told that I have only 7 minutes. I'm not going to go into the details, but when you're doing the RF ablation of trigeminal, it's very, very important that you explain the procedure in detail. And if hematoma or if there are post-operative complications, you should be ready intraoperatively proper. So these things go unsaid, that you have to take care of all of them. So coming to the surgical techniques versus the percutaneous procedure, as I said, the younger patients, definitely I would like them to go for a surgical technique, but you also have to keep it in mind the invasiveness or the morbidity which is associated with the technique, surgical technique. So when we see that the relief, in terms of pain relief, we have compared. So we find that the surgical technique as well as RF ablation has an equal amount of pain relief. The efficacy in terms of pain relief is very good and it is comparable. And also this recurrence rate, when it comes to actually RF, it is much less than the microvascular decompression. So I preferably feel that when it's such an invasive procedure, we can definitely go ahead with the RF ablation, and you should give a choice to the patient and explain all the pro and cons regarding the procedure to the patient when it comes to the interventions. So thank you, Karthik.
Thank you, Dr. Pratibha. Nice lecture. Probably 7 or 8 minutes is not enough to finish trigeminal neuralgia. To start off, can you throw some light on, just for the sake of junior pain physicians, exactly how is your treatment algorithm? You have diagnosed it, you have done the MRI. So when do you consider conservative? When do you think of microvascular decompression? When do you offer percutaneous? In what age group? Can you clarify that clearly for the juniors, please?
Yeah, so if it is a younger patient who comes with the trigeminal neuralgia, and suppose most of the times we know the progression of the disease, not all of them will come with severe pain. Sometimes the period of remission and exacerbations are different in the initial phases of the disease. So that time, definitely you have to start with the pharmacotherapy, and carbamazepine is a wonder drug. It works really well. Oxcarbazepine is equally good with a very good side effect profile, and most of the patients, I think, respond very well for the pharmacotherapy. And if suppose they are not responding, or if you are increasing the dose and they have lot of side effects, and most of them, like most of the patients who are coming to me are like driver profession, so they cannot afford to increase the dose of the drugs that they are taking. So in that case, then I think the role of intervention comes if you cannot increase the dose of drugs, or if they are ineffective. If the drugs are ineffective, or if the doses the side effects are much more, which is not tolerated by the patient, then the role of intervention comes. Now coming to the interventions, I think if it is as I had already told in my slide, that if the patient is in a younger age group, suppose if it is like a 40-45 years of age patient, then and you have done, and almost all the patients we do MRI, because we want to rule out the secondary cause and also the vessel loop, microvascular loop decompression. So when you have the evidence of vessel, then definitely I think you should go ahead and tell the patient, explain the patient about the different techniques that are available for him, that is surgical techniques and the percutaneous intervention. And I think we'll have to agree that RF doesn't last lifelong. It will definitely, everybody has different results in their practice, but the minimum is I think 2 years, and then it can last for longer also. But every 2 years, it may not be possible for the patient to come and do the procedure. So I think that you should give the choice to the patient that this is what is there. The realistic expectations should be there from the patient, and then you should go ahead with the procedure. And I would prefer RF ablation as one of the technique, which is a preferred technique for trigeminal neuralgia. And as I said, if it is an ophthalmic division, then the balloon decompression. But not everybody here. I also want to tell that these are the techniques which require a lot of skill. It requires a thorough knowledge of fluoroanatomy, and the complication rates are quite high if it is not done properly. So I think the juniors should do all these procedures under guidance in the beginning, and then you should go ahead to do it independently.
Okay, Karthik, can we take some questions here?
Yeah, please.
Okay, so there's a question from Dr. Sunita that patient has undergone a surgery for trigeminal neuralgia. Don't know what surgery, but patient has undergone surgery, and then post-surgery, patient has come with a recurrence of the pain. So what is the management in such cases? Means recurrence after the surgery.
I think in the post-surgery recurrence, definitely, I think RF ablation is one of the choice of intervention for these patients, because as I had in my last slide, you had seen that the recurrence rate with surgery is quite high in 5 years. So that's the reason why you need to explain also. And I have also in my practice also, I get a lot of patients who come with recurrence after the surgery. So RF ablation, you should go ahead with RF ablation and explain all the pro and cons, because already I think the patient must be very anxious that the patient has a relapse after the surgery.
Yeah. So repeat this thing RF is also is advisable that when you undergo some RF procedure, if you do RF ablation and the patient comes back to you after 6 months or 1 year, you can always repeat the procedure. Similarly, for the post-surgical also, we can do that. So one thing I would like to mention here about the MRI testing. So if you have a patient with a trigeminal neuralgia, and if you have to order MRI, it is always better to write down the MRI trigeminal protocol. You always write that. Just don't order MRI brain. So if you order the MRI trigeminal protocol, then you can see starting from the pons to the coming to the peripheries of the nerve, all the divisions of the trigeminal ganglion. They'll take all the sections from there. So with this, you can make out where is the compression, or there is some compression, secondary causes there. So it is always better to write down MRI brain with trigeminal protocol. Always write down this thing. So this is just one more comment from my side. And,
okay, one more comment and question is there from Dr. Rajiv Harshe, and it is very important, I think, in clinical practice. So you have a patient who has multiple procedures done, like he has underwent surgery twice, he has underwent RF ablation twice, patient still in severe pain. So I would like to have your opinion, Pratibha, and also if we can add Maithili or Ruchika Sood to the such situation, what should we do? Let's have a multidisciplinary approach in this case.
In my opinion, first and foremost, I also find a lot of patients who are misdiagnosed for trigeminal neuralgia. So there is many times the diagnosis is not correct, and then the patient lands up into wrong hands, or the procedures are not done by people who are skilled in doing these procedures.
Patient has underwent twice. He has underwent surgery, and twice he has underwent RF ablation at 2 different centers.
Then I think it is very necessary. It's very important that we re-look into the diagnosis of the patient, and we need to find out if the pain generator is something else than the trigeminal neuropathy, means the neuralgia.
Yes.
So there are 2 terminology what we are using now. See, these are very important terminology. One is trigeminal neuralgia. The neuralgia is different from neuropathy. Okay, so can we have either Dr. Ruchika Sood on line, so we can have their opinion?
So for these cases, first of all, we will look at, like Dr. Pratibha appropriately said, what is the generator of the pain. So in my experience, most of the patients who come to us in these conditions, they have a stronger peripheral input for neuropathic pain. So whether the input is more from the PNS, peripheral nervous system, or the CNS. So peripheral nervous system, we try to figure out in the facial part where it is, and about 50 to 60% of pain relief is achieved by approaching the local part. So for example, like we make the stent and we give a local anesthetic gel or compounded medications and ask the patient to keep it at the part from where the pain is generated, and get about 50 to 60% pain. The approach is all about breaking the pain cycle, and use a different combination of medications, whether duloxetine, Lyrica, or gabapentin, and try to bring the pain relief. Neuropathy is a sustained pain state, and so I think that's what we do most commonly.
And neuralgia is an intermittent kind of a classical trigeminal neuralgia presentation.
Dr. Preeti
most
Doshi
patients
can comment on this thing. That is
most patients they go in neuropathy if multiple procedures are been done. Yeah, Preeti, you can come in and share your experience.
Can you share, because is there any role of neurostimulators in such cases?
Yes.
Dr. Preeti?
Yeah, you are audible.
Yeah. So if we have
maybe you can come near the mic, because it's
just bring your
less.
yeah. Yes.
Better. Hello.
Can you increase the volume?
Little more, increase the volume.
No, you have to increase. You have gone down, I think. Maybe you can just use the.
Is it better?
Okay, go ahead.
Hello. Can you hear me?
Yeah, go ahead.
You're audible, but yeah, it's okay.
Okay, so I think as my colleague panelist said, first of all, we have to make sure that we are looking at the correct diagnosis. Because if the pain has recurred every time after doing, 3 or 4 major interventions, we have to establish whether we have arrived at the right diagnosis. And if it is correct, and if these therapies are only helping for a short duration, one can definitely consider role of a neurostimulator. So peripheral field nerve stimulator is one intervention which can be considered depending on the distribution that the patient is experiencing pain in. However, it's an invasive therapy, so before we offer that, we should definitely, make use of multimodal other approaches, including optimizing the doses of the drug. And spinal cord stimulator or peripheral nerve stimulator will come as a last step in the algorithm of interventions. So that is very important. I think continuous medical management, optimizing drugs would be a more sensible step because the patient would often be disheartened because already undergone 4 major interventions without, adequate pain relief. So first of all, they need a lot of psychological counseling also if they have to undergo these stimulation therapies.
Okay,
Yeah,
so
Priti, you can check your mic because during your
it's not
lecture.
heard.
So for the
Yeah.
audience, it is that Dr. Vidhi is saying is that peripheral nerve stimulation is an option as a last option. If it is nothing is working, in those cases we can go for the peripheral nerve stimulation. That is one of the options we have available now. Okay, Karthik. Now I think we do not have any much questions or comments over here.
Yeah. So
This
next is Preeti ma'am. Do you want some time to fix your mic, or you're okay?
Can you
I
hear
think
me now?
I think you should change your ear mic.
It's volume is very low, Priti. You
so I
have
think
to.
we can start with Dr. Jitendra.
Yes, ma'am, can you fix your mic by then? The next one is Vasopharyngeal neuralgia by Dr. Jitendra Jain, please. Dr. Jitendra Jain, are you here, sir?
Hello, can you
Yes,
Yeah.
yes, you are here.
Yeah. Am I audible?
Yes.
Yes,
Is
audible.
it clear?
Yes.
Clear.
Okay,
And-
so Karthik, are you relaying the slide or you want me to take one?
Okay, if we can do it, it's perfect.
Okay, I'll do that. Just give me a minute.
Yeah.
Hello, can you hear me?
Yes, Jitu, go ahead.
Okay, can you see?
Yes, yes.
Okay, so my topic is glossopharyngeal neuralgia, which is one of the practice along with the other facial issues. The thing is that it's not very close compared to trigeminal or other facial pains, but that poses problem as well because sometimes we don't know what we're dealing with. And in fact, glossopharyngeal nerve is basically been called as a neglected cranial nerve. So, etiopathogenesis of glossopharyngeal neuralgia, primarily it is idiopathic, where we do not have much of a cause. Secondary glossopharyngeal neuralgia has various reasons. As you can see the list over here, where there is vascular compression, which is commonly involving posterior inferior cerebral artery. Oropharyngeal cancer is the second most common one. Eagle syndrome, where we have styloid process or a stylohyoid ligament, which is actually pressing on the glossopharyngeal nerve. Demyelinating disease, multiple sclerosis is also one of the reasons why somebody might have glossopharyngeal neuralgia. Autoimmune or inflammatory diseases, peritonsillar or perioral infection. In fact, there are case reports where the tonsillectomy has been done and patient has developed glossopharyngeal neuralgia because of kind of an entrapment syndrome. Intracranial, I think that's a spelling mistake there. Space occupying lesion around the CP angle is also known cause glossopharyngeal neuralgia. In terms of the incidence of this particular, this is mainly a US data which was taken around about in I think mid 80s or late 80s. That's when this particular article had come down. 0.2 to 1.3% of all cranial neuralgias, that's the incidence of glossopharyngeal neuralgia. Now, in regards to the epidemiology, there is about 0.7 out of 1 lakh people might have glossopharyngeal neuralgia. The gender ratio is fair to both the sexes, male and female, it's equal, it doesn't bias. Middle age is more common, although the age range has been between 20 to 80 years. But you see it more common in middle age group, which could be 40 to 60 years. So most of us probably are in the stage we might have glossopharyngeal neuralgia, hopefully not. Now, the remission rate for glossopharyngeal neuralgia is about 74% with annual recurrence of between 3 to 4%. Now, ICHD, that is International Classification for Headache Disease 3, which came out last year, has criteria for glossopharyngeal neuralgia, where it says that the recurrent paroxysmal unilateral painful attack in the glossopharyngeal distribution. So it starts from the inner side of the tympanic membrane, goes to the eustachian tube tract, deep nose, throat, tonsillar fossa, comes to the base of tongue, and it also gets referred to the angle of jaw. Now, following is actually the characteristic, which is a brief episodic pain, which lasts for a few seconds to few minutes, and suddenly it stops for no rhyme or reason. So it comes and goes like any other neuralgic pain. And it is usually a fairly severe intensity, and the intensity is so severe that patients are actually scared to get this particular pain, which is sharp and shooting in nature, electric current-like pain. It is precipitated by coughing, yawning, swallowing, and talking. So anything which stimulates the trigeminal nerve in that particular distribution can trigger this particular pain. So any stimulation or any trigger in the glossopharyngeal nerve would definitely, especially if the patient has glossopharyngeal neuralgia, would be having this brief episodic pain which lasts from seconds to few minutes. You have to rule out other causes of facial neuralgias, obviously. You might have syncope, which happens in about few percent of patients, 2 to 3%, because there is interconnection of glossopharyngeal nerve with vagal nerve. And because of the constant pain that some of, not constant, but episodic pain that these patients have, there could be loss of appetite because they're afraid of eating, the loss of weight, obviously, because they're not eating much. Depression, because of, if it goes on for a long time, hyperalgesia in general, because patient has a painful state. History is mainly diagnostic. MRI, X-ray are actually supportive to rule out any other secondary glossopharyngeal neuralgia causes. So the treatment for this particular thing, obviously you start with pharmacological treatment first, and as any other neuralgia treatment, you would be following the guideline for any neuralgia. Neuropathic pain management medications, which starts with, I think for facial neuralgias, carbamazepine is an option to start with, which is easily available, relatively cheap as compared to other medications. Gabapentin is an option. Pregabalin, if patients do not respond, combine that with other medications like maybe tricyclic antidepressants or SNRIs. Then we can go on to the second ladder and third ladder. Some of these patients do have a reasonable response with medications like topiramate, sodium valproate as well, but that is debatable again. Now, the most interesting part for most of us who are pain specialists is we would like to do glossopharyngeal nerve blocks. Now, glossopharyngeal nerve blocks is considered firstly diagnostic, that whether we can go ahead and do a neurodestructive procedure or not. And if at all patient improves, and if patient wants, they can opt for surgery, because if patient improves with that, the chances of patient improving with surgery is much higher as compared to patient who do not improve post-nerve block. Radiofrequency ablation is definitely much more safer. Uh, Neurolysis with alcohol is a possibility. I don't have much experience with alcohol neurolysis, but we need to be careful because it is in very close vicinity with the vagus nerve. So severe bradycardia is a possibility. Some of the patients, in fact, even with RF, one of my patients I remember had severe bradycardia. I had to give it during the procedure. So one needs to be very careful when you are doing neurolysis procedure. The volume of alcohol needs to be very controlled, and RF needs to have a very good stimulation. If the stimulation is causing bradycardia, don't go ahead and do RF. Maybe pulsed RF would be a good option. Surgical options there are, because there are secondary glossopharyngeal neuralgia causes, which results because of maybe a vascular loop, there might be a tumor around, there might be a stylohyoid ligament. So various surgeries have been described by neurosurgeons, ENT surgeons, depending on their expertise. MVD is one of the commoner ones because probably patients get referred to neurosurgeons more often. Some of the ENT surgeons might not be comfortable dealing with these invasive surgeries. Intracranial stereotactic radiofrequency ablation and nerve sections of glossopharyngeal has also been described. Out of all these three, the safest and the long-term option that they have found, which was there in one of the meta-cell analysis which came out about a few years back, was nerve section. That means you ablate, not ablate, but you cut that particular nerve, and the patients get fairly good pain relief. And MVD was the second best, and intracranial stereotactic RF was not that great. Now, coming back to our very own domain of doing glossopharyngeal nerve block and radiofrequency ablation, it's been described under fluoro, where you try to hit the styloid process. CT guided, obviously, you go to the styloid process, and ultrasound guided. I have only experience with CT and fluoro. I don't have any experience with ultrasound guidance. The way we go is you try to hit the styloid process at the lowermost part. The reason for doing at the lowermost part is because it sort of tries to separate it from the vagus nerve, and it is little away. And then you go posterior to the styloid process and inferior, stimulate that particular area if you can. If you can get a stimulatory parameters met, very good. If not, inject about very limited up to 1 ml of local anesthetic. See the patient's response. If patient responds very well, good enough, you found your diagnosis. Sometimes even just one single diagnostic block can become therapeutic. If the patient's pain recurs, do an RF ablation. That's what I would prefer in comparison to neurolysis, especially if the patient doesn't have oncological issues. This is what I would be doing. Now, complications with these procedures is this particular procedure, there could be dysphagia, obviously, because it supplies stylopharyngeal muscles. Pharyngio-laryngo-tongue numbness, because you have numbed that particular distribution of glossopharyngeal nerve. Regurgitation is a possibility in these patients. Hoarseness, obviously, because you might get, because the nerve is actually a bit close to the recurrent laryngeal nerve. So you might land up burning that particular nerve or purulite that particular nerve as well. So this is what, in short, is about glossopharyngeal neuralgia. If anybody has any questions, you ask.
Nice and crisp, Dr. Jain. Thank you. In terms of how often in your practice do you do a diagnostic block, and is it always?
I always do. Before doing any neurodestructive procedure, be it any procedure in the body, from top to bottom, always, because sometimes just a diagnostic block itself becomes therapeutic. I just leave the patient alone, minimal medications, leave them alone. If they come back, usually I call them back after about 4 days to 5 days, maybe a week. And if the patient's pain has come back within a few days, or it hasn't come back, very good. If it has come back, I might give them the option. But this is all primed before I do the diagnostic. So you have to counsel these patients before, because sometimes they think that you're doing an interventional procedure. It's going to be magic to these patients and they would be cured, which not necessarily will happen on the cases. So you have to counsel these patients before you actually go and intervene with any needle in the body.
Right. And you mentioned about fluoro-guided blocks.
It's difficult. It's difficult. It's not that easy.
And if
because
there is no styloid process,
Correct.
I mean, elongated styloid process, it's a little tricky, right?
Yeah, it is. It is tricky. It is tricky. Sometimes when you're going blind, at least it has happened to me a few times. Not that I've done that many, but there were a few patients I remember. I tried and struggled, and then I went back to the surface anatomy factor, where you go in the midpoint of the angle of the jaw, mastoid, go the center of it, go perpendicularly in towards the vessels, and try and go about 2 to 3 centimeters inside and try and
Ultrasound has
stimulate.
a good role. Ultrasound has a good role here, I think.
Yeah, possible. I don't have much experience with
A lot
that,
of
but probably
sickness
that's a
here.
good option. Yeah.
A lot of vascular sickness also there. So I
Correct,
think
correct,
probably
correct.
ultrasound.
I have a picture there, but I didn't understand anything in that particular picture.
Yeah, just a word of caution for all the listeners who are listening. Glossopharyngeal and trigeminals, they're all advanced blocks. You should be doing them only after you've achieved a reasonable amount of training and you're comfortable doing other procedures. In my opinion, glossopharyngeal nerve block is probably the most risky block in interventional pain. So a word of caution there for younger pain physicians.
No, I agree to Karthik very much. What he's saying is because these sound very easy and simple. The therapeutic advantage could be a great advantage, but not necessarily it's easy to do. I mean, patients can die because of these procedures, so you have to be careful. So always exhaust your pharmacological option first. Rule out other reasons. If patients don't improve after pharmacology, revisit your diagnosis. It's not a bad option to do because it's a pretty harmless thing to do. So revisit your diagnosis. And if you have any confusion before doing any procedure, I think we all are around. Anybody can take our guidance.
So Dr. Jain, one question is there. So what is your preference, whether it is a pulsed RF or conventional RF?
I would do conventional
Dr.
RF.
Pushpinder Singh,
I will do
he says,
conventional
isn't pulse RF is better for glossopharyngeal now?
Well, I mean, I would do a diagnostic first. So if diagnostic works, it might work as a pulse RF for me in some patients because I'm banking on diagnostic to become therapeutic on its own. But if not, if it comes back, probably I would consider a pulsed RF, a conventional RF because I'm not sure about the longevity of pulsed RF. I'm not convinced actually.
So you prefer conventional RF. And what is
Correct.
the role of
Because
steroid in diagnostic block? You do steroid or plain xylocaine?
no, unless I'm looking at Eagle syndrome or maybe an oncological issue where I'm thinking that there could be compression and causing neural edema, then I might. But in general, not necessarily I would be adding steroid in most of my diagnostics.
So if you have a cancer causing compression of the glossopharyngeal, steroid
That's
is
again a
used.
controversial thing because the anatomy is distorted. Not necessarily you'll be able to reach where you want to. So maybe CT guided might be an option. But again, you need to confirm that
Even
you
in
are
CT,
in the right area.
CT you
Correct.
can't see the nerve.
Correct.
So it's
Correct. You
a tough
can't see
thing.
it. You're going by styloid. And hopefully the styloid still exists, that the cancer has not eroded the styloid.
Yes.
So maybe the great vessels could be a guide here.
So is the injection of some chemical neurolytics is better than RF in such situation? In
Maybe.
cancer,
I think
especially?
that's definitely an option available, but I don't have that much experience regarding that because most of my patients have been non-onco. And I'm a bit wary of doing glossopharyngeal block in
Yes.
some
It's the
of
last
these
option.
patients.
Yeah.
Correct.
Just
Okay.
one last doubt is, can you do an intraoral approach to the glossopharyngeal nerve block?
You can. It's been described, and quite a few of ENT guys do it. It's been described, uh, but most of us probably prefer the external approach, not the intraoral approach.
Right.
It's been described definitely.
I just wanted to add, Jitendra,
Yes.
that I get a lot of cases of from the ENT surgeons who have post-styloidectomy, they come with the neuritis.
Correct. It's
And
not
here
uncommon.
the role of,
It's not
like
uncommon.
Kailash was asking for the role of steroids. In such cases, local anesthetic with steroids, post-surgery, patients who come back with the recurrence of pain, here the local anesthetic with steroids work very well.
Fair enough.
So there's a comment from Dr. Ashu Jain. He says we can try stellate ganglion block in cancer pain, which is very valid. because any
Correct,
facial
correct,
pain can
correct,
respond
correct.
to. So in patient who is having cancer with this kind of neuralgic pain, you can always think about stellate ganglion. Thank you, Ashish. Yes,
Um,
Karthik, you can go ahead
yeah,
now.
thank you, sir. I think we'll go to uh, atypical facial pain. Dr. Preeti Joshi is ready.
Can you hear me now? Am I audible?
Not much.
No choice, you can go ahead now.
Okay,
It's
that's
better.
hello. Okay, fine. So thank you very much, ISSP, for giving me this opportunity on this very important panel discussion about orofacial pain. So Karthik has given me a difficult topic, which is atypical facial pain. Now that actually is an obsolete term, and according to the newer nomenclature, it is known as persistent idiopathic facial pain. It is mainly a diagnosis of exclusion after ruling out the more common neuralgic pain syndromes. It's a persistent facial or intraoral pain, and it's a heterogeneous group of patients where they complain of pain on an everyday basis, at least for 2 hours, for more than a duration of 3 months, in absence of any obvious clinical neurological deficit. The prevalence actually is much lower than the other types of cranial neuralgias. However, one has to keep this important diagnosis in mind to offer them the correct treatment and not to miss out the other treatable facial pain conditions. We do not know the exact mechanism, and that is why it's a perplexing condition with, not very good outcomes of the management that we offer. Uh, Nobody knows exact mechanisms, and that is why we don't have any mechanism-based modality approach. However, what I can say is the pain intensity is much disproportionate to the extent of injury, and it often just starts after a trivial most trauma or surgical
Yeah,
procedure.
Priti, sorry to interrupt. Can you try using without earphone now? Because I think people are having a lot of trouble in
Hello.
hearing you. Yeah, it's better, I think.
Okay, better.
Yeah, yeah.
Okay. So, so as I said, it is presumed there are a lot of hypotheses and mechanisms in research and which banks upon the principle that it is due to the abnormal sensitization of the trigeminal nociceptive system. The pain this patients would have is often very vague, and it's a deep, dull aching, burning, throbbing, or stabbing kind of pain, which is poorly localized, not confined to any one nerve distribution. It is generally unilateral, but could often be bilateral, and it is mild to severe intensity of pain. So sometimes it can be very, very troublesome. The patient may be suffering for years together, and it is considered by many as a wastebasket diagnosis where you have to exclude the other treatable conditions. The management is obviously a big challenge with a limited response in view of the fact that there is no clear-cut etiology that you can pinpoint. However, there is a lot of research and literature going, which says that you have to first of all rule out the other primary causes like neurovascular trigeminal autonomic cephalalgias, regional myofascial pain syndromes, or atypical regional neuropathic pains. And these are often misdiagnosed, and patient often presents with a dental pain or a pain which they feel has an otolaryngological origin, and that is often mistreated in form of many invasive procedures, and that would lead to a whole spectrum of condition. These are the different phenotypes. So it may either be a persistent idiopathic facial pain, or it could be even painful traumatic trigeminal neuropathy, which my previous speakers have already explained. So coming to the management of this condition, we have to advocate multidisciplinary and multimodal approach, and we have to always use non-pharmacological approaches in conjunction with the pharmacology and interventional approaches. So try and counsel the patients, try and offer them stress reduction measures like mindful-based stress reduction techniques, hypnosis, cognitive behavioral therapies, and so on. Pharmacotherapy wise, again, this condition does not respond very well to the pharmacotherapy. However, one can use tricyclic antidepressants and serotonin, noradrenaline reuptake inhibitors like duloxetine, venlafaxine, and fluoxetine. One other recent therapy which has been advocated is a high frequency repetitive transcranial magnetic stimulation. When you provide this therapy over the S2 or the secondary somatosensory cortex, this has found to give promising results, and it is a non-invasive therapy, so one should definitely consider this if the patients are not responding to the other simpler measures. In terms of interventions, of course, we don't have adequate evidence again, but a pulse radio frequency ablation of the sphenopalatine ganglion can be considered in patients who have not responded to any other drugs or any other measures, and when we have ruled out the other etiological pain generators. Um, in terms of outcome, we have to monitor the result of the therapy that we offer on the functional imaging studies, the QST and other neurophysiological tests to collect our data and to try and find a better solution to this difficult and perplexing condition. Coming to the next part of my talk, which is the sphenopalatine neuralgia. Now, in fact, this is an older term according to the ICSD third version classification, and this is actually considered as synonymous to cluster headaches. This is a primary neurovascular headache, which strictly is unilateral, associated with cranial autonomic features. It generally has a circadian and circannular patterns, so where the patient will complain of pain for hours or days together in a cyclical pattern. Generally, it can also occur at night time and at a fixed time of the night. The etiology is not exactly known, but however, there is a role of hypothalamus, which is proposed as a possible mechanism with release of neurotransmitters like histamine and serotonin. Uh, and there are two basic types of cluster headache. It could be an episodic, which can last anywhere from 7 days to 1 year with a remission for at least 3 months, or a chronic cluster headache, where the duration may be more than or equal to 1 year with a remission of less than 3 months in between. And when it becomes chronic, the management really becomes quite challenging. It generally involves males more as compared to the females in the third to fifth decade of life. And that is why it's very important, because at times it can be really disabling in terms of the clinical symptoms. The diagnosis as per the ICSD version 3 has to be established, and which I'm going to show in my next slide. However, one has to be sure to rule out any other differential diagnosis like atypical migraines involving the face, Sung syndrome, uh, paroxysmal hemicrania, or trigeminal neuralgia, atypical trigeminal neuralgia. So, according to the ICHD3 version, the diagnostic criteria are that you need to have at least 5 attacks fulfilling criteria B to D. So, the patient will suffer from severe or very severe unilateral orbital or periorbital or temporal pain, which will last anywhere from 15 minutes to 3 hours if untreated, and either or both of the following, number 1 and number 2. So number 1 will be showing autonomic features on the ipsilateral side of the headache in form of conjunctival injection or lacrimation, nasal congestion or rhinorrhea, and edema of the eyelid, facial or forehead sweating, and meiosis and ptosis. At the same time, they could also have just a sense of restlessness or agitation. So this, according to the newer classification, the patients may not have autonomic features, and still they fall into the diagnosis of cluster headache. So occurring with a frequency of 1 every alternate day, or there may be up to 8 attacks in a day. And this is not better explained by any other classification of the international classification for headache disorders. Okay, so management, coming to the management, again, we resort to the multimodal options in form of the non-pharmacological measures, stress reduction, sleep hygiene, avoiding the trigger factors which can commonly trigger cluster headache in form of stopping smoking, alcohol, any food substances which could trigger the attack. Most effective treatment is 100% oxygen at 15 liters per minute with a non-rebreathing mask, and that brings about pain relief in about 15 to 20 minutes. Another very commonly used drug is a calcium channel blocker, verapamil, which can be given in the doses of 240 to 720 milligrams. Prednisolone is of use in acute phases. Triptans can be used with moderate response. However, if it is another differential diagnosis, then we can rule that out if the patient responds favorably to triptans. Melatonin, dihydroergotamine, valproate, and there are some newer drugs like galcanezumab, which is a monoclonal antibody and which has been shown to have quite promising results. Coming to the interventions, the commonest intervention which we can perform for a patient with intractable cluster headache which doesn't respond to medications is the diagnostic block followed by radiofrequency ablation of the sphenopalatine ganglion. Occipital nerve block has also been found to be effective, and then one can go ahead and perform an RF ablation of the occipital nerve. Non-invasive vagal nerve stimulator and vagal nerve stimulator subcutaneous or internalized can also be considered. And the last but not the least, a sphenopalatine ganglion stimulation can also be considered for these patients. So I think most of you know that there are two different approaches, a transnasal approach, which can also be used first to establish the diagnosis. It can be done either in a blind manner, if you know the anatomy well, or with the help of an endoscopic technique, and where you introduce the flaget, which is dipped in a local anesthetic, mainly 4% xylocaine, in in up to into the next to the middle turbinate in close proximity with the sphenopalatine ganglion, and you leave it there for about 20 to 30 minutes. And if the patient gets pain relief more than 1 hour, then it is said to be a positive response. These patients can then either have a series of such blocks or they can be offered a radiofrequency ablation. Radiofrequency ablation has to be performed under image guidance. This is the lateral intrazygomatic approach which we advocate, and we have to do a diagnostic block followed by a pulse radiofrequency ablation. And lastly, if the patients have really intractable idiopathic facial pain or cluster headaches, or even for that matter, trigeminal neuropathic pains, we can offer a whole gamut of stimulation techniques where we have supraorbital and intraorbital nerve stimulators. We have a sphenopalatine ganglion microstimulator. We have occipital nerve stimulation as shown here, and we have auriculotemporal nerve stimulation. And there are studies which have shown even the high cervical spinal cord stimulation can help with intractable facial and headaches. Lastly, we have one more gadget in our armamentarium, which is a vagal nerve stimulator, has been found to be effective in intractable cluster headache pains. And these are some of the references, and I would like to thank you all.
Thank you, ma'am. So the lecture was good, but I think some of them had some issues with the audio, right? So in terms of treating patients, I understand that treating cluster headaches can be very, very difficult. And sometimes as pain physicians, we struggle with these patients and some of the interventions do not work. Is there any magic formula in treating cluster headaches?
So by and large, I think the drug verapamil has found to be quite effective. That's the first line treatment in addition to the oxygen. So oxygen also is found to be very, very effective, and that is why these patients have to have a facility of home oxygen. And the moment they start getting an attack, they have to start with the oxygen inhalation. It can be anywhere from 7 to 15 liters per minute rate, and it has to be inhaled. And within 20 minutes, the patients get good relief. If the attacks are very, very severe, then we can also consider putting them on a short course of prednisolone, which has then to be tapered off once the attack is under control. And we have a lot of preventive drugs also. So triptans can also be effective. Sumatriptan especially has been found to be effective to abort an attack of cluster headache if they get the attack and it's not helping, it's not being helped with the regular medications. So one can consider using triptans like sumatriptan or naratriptan. Dihydroergotamine also has been used with debatable efficacy, but that is an option also which one can consider. And I think a transnasal sphenopalatine ganglion block is also very effective if you can teach your patients how to place a transnasal gadget into near the middle turbinate. It's quite a straightforward technique, which if your patient is understanding enough, you can even teach that. Or you also have lignocaine sprays, 10% concentration, which also has the tubing and delivering tube. So you can use that also to abort an attack if none of the other things help.
Right, ma'am. Thank you. If there are no more doubts, can I go to the next speaker, please? Thank you, ma'am.
Thank you.
Dr. Ashish, are you ready? We are going to be.
Yeah, I am ready. You might have to. Yeah, you might have to play the slide for me, please.
Are you sure?
Yeah.
Okay.
I have actually issues with the Wi-Fi here. I'm on the phone.
Just give me a second. You can start the talk. I'll.
Yeah. Okay. So first of all, thank you, ISSP, for giving me an opportunity to speak on this a topic which is of grave concern to us, and that is orofacial cancer pain. And the one thing that I would want to state right at the beginning is that this orofacial cancer pain is quite very different from what you observe in pain states occurring at different, for example, in GI or in case of pelvic cancer pain. So the main importance is because where you have a dull, diffuse sort of pain which is crampy in nature in case of GI and pelvic, the orofacial cancer pain has got a peculiar pattern which is sharp and which is localized. Second is about the functionality. In the other types of pains like pelvic and GI, you don't have so much hindrance with the functionality of the patient. But that's not the case with orofacial cancer pain. The functionality will be significantly decreased. The patient will have problems in talking, eating, swallowing, and doing the regular, things which is essential for our life. And the function-related pain will be like the moment he opens his mouth to chew something, or to talk, or to even smile, it brings about pain on his face. Third thing about, because it is very sharp and the pain is quite very intense, the escalation of opioids is quite very high in case of orofacial cancer pain. So if you have a high escalation index of opioids, you can definitely anticipate that the patient will also have high chances of side effects of opioids, like this high occurrence of opioid-induced analgesia, hyperalgesia. The next slide, please. The next slide, please. Yes. Okay. So the mechanisms here, as we very well know, is one peripheral, this perineural invasion. But that is not all. Definitely the humoral factors which are secreted by the tumor cells, especially the nerve growth factor, that has got a tendency to make the tumor cells neurotropic. So that is why the patient usually will present in a stage where the nerve cells, the tumor mass has already involved the nerve, and that is the main cause of pain. But that is not all. These nociceptive mediators that is secreted by the cancer cells, they also sensitize the receptors on the neurons. So once these neurons are sensitized, they also have this problem of the self generation of signals, which can lead to allodynia or hyperalgesia. The next important cause is that of referred pain, and most commonly it is the intracranial referred pain. And you would usually see that the tumors, they mainly involve the trigeminal ganglion or the fifth cranial nerve, the seventh cranial nerve, and the ninth cranial nerve. So the involvement of fifth cranial nerve would present as a facial pain. Seventh nucleus, cranial nucleus, will present as nervous intermedius neuralgia, wherein the patient will have pain in the ear canal, which will be simulating glossopharyngeal neuralgia. But here the difference is the patient does not have pain in the throat, or the patient does not have pain while swallowing, but the patient has pain in the ear canal, external ear canal. And third, we have already dealt with in detail with the glossopharyngeal neuralgia. So that is yet another manifestation of referred pain. So another thing, can you go back to, okay, let it be here. Another thing that we would want to understand is that what about the role of mediastinal tumors? Can it have manifestation of facial? So what happens is when the mediastinal tumor involves the vagus, as in this diagram you can see, the vagus also converges onto the nucleus caudalis of the trigeminal ganglion. Sorry, the trigeminal nucleus. So because the fifth cranial nerve as well as the 10th cranial nerve are converging, are having the same area of convergence, the pain pattern is conducted over to the face. Next slide, please. The same thing you would find, the next slide, please. The same thing you would find if there is an involvement of the somatic nerves anywhere above C2 level. Now, the same mechanism involves, that is the C2 cranial nerves, the C2 somatic nerves, they also converge onto the nucleus caudalis. So this was a patient who had had a tumor involving the anterior arch of the atlas, and she was presenting as frontal and the facial pain. Next, please. Paraneoplastic syndromes are quite very rare in case of facial pains, but there is a paraneoplastic syndrome described wherein the patient had squamous cell carcinoma of the lung, the small cell carcinoma of the lung, and the patient presented with trigeminal neuralgia and diarrhea. So the mechanism of paraneoplastic syndrome is the body secretes antibodies against the tumor cells, the receptors of which the body recognizes as foreign. And these antibodies in turn, they regard the receptors on the neurons as foreign proteins, and they mount the antibody antigen reaction over that. Now, there can be pain due to treatments, like we have already dealt with the post-traumatic trigeminal neuropathy earlier. So this surgical, if there is any surgical intervention taken, that can later on present as myositis, this myofascial pain, or maybe a temporomandibular joint dysfunction, or maybe even neuropathy because the nerves are severed, or because of the nerves being severed, it can present as type 2 CRPS. Regarding chemotherapeutics, they can cause both stomatitis, and they can also lead to peripheral neuropathy. Same thing goes with radiotherapy, and radiotherapy can also lead to osteonecrosis of the jaw, and also they can cause some changes in the endothelium, which can decrease the blood supply and can render the tissue hypoxic. Opioid-induced hyperalgesia we have already dealt with earlier. And so this was the pain due to treatment. So there is an entity which I would like to cause pain due to ill treatment. So ill treatment comes from the treating physician, the patient's relatives, and the patient himself. So the treating physician may think that at a particular stage, he may not think that that stage is adequate enough to cause so much of pain. So if the patient does say that the pain is out of proportion, the patient may pass it off as malingering or attention-seeking behavior. The patient's relatives, they already have considered that the patient is a goner now. So the patient, they do not have so much of, and they think that because they do not have any options left, they cannot do anything further. So that is yet another problem. The patient starts to think that everything is doomed, and they develop nihilistic attitude. So because of that, they go into depression, and that adds on to their problems. Next slide, please. We have already dealt with this earlier. Next slide again. So what about the management of such patients? So definitely, if there is a cause which is leading to a problem, that cause has to be removed. So if the tumor is the cause, then debulking of the tumor, not only by relieving the pressure from over the nerves, it can also decrease the humoral secretions of the mediators that we have already talked about, and that is how it helps. And definitely, if there is a infected material or a sequestrum, maybe because of osteonecrosis, even those things, taking care of those things can help. Management of neuropathic pain has to be in two limbs, has to be in the, you have to consider the somatic as well as the sympathetic limb. So not only we had already talked about trigeminal neuralgia and glossopharyngeal neuralgia, but in addition, you have to think about the stellate and the sympathetic tree as well. Management of nociceptive pain according to WHO ladder. Here, initially the WHO ladder was formulated to decrease the misuse or abuse of morphine. So there was the definite step ladder pattern in which you would go to step 1 first, and then 2, and then 3 onwards. But then you realize that these patients are already so much in pain and so much in debility that you should start higher up in the ladder, and then you can titrate on the way down, so that the patient does not have to bear with much of a pain. And maybe sometimes, you know, you might even have to cessate the treatment for a brief period of time. For example, we have already talked about the chemotherapeutics and the radiotherapy sessions, they cause mucositis. So those things may be given a break if you already think that, I mean, depending upon the judgment, if you think that you can briefly terminate it, for say around 4 weeks or so, the this will go in a long run to help the patient with the symptoms. Now, many of us, especially when we are deep into our practice and many years into practice, we start believing ourselves as, you know, not only pain physicians but also psychological counselors. But that should not happen, actually, to be speaking, because you know, these types of patients, they really have to be well educated or well motivated, and we do not have time enough to do the same. So these patients should definitely have a psychological counseling, proper psychological counseling by an expert, and the same should be trained to the family and the friends also, so that the patient now starts focusing on the quality of life and not on the quantity of life. Definitely the patient knows that the life is going to end soon, but then if the patient knows that whatever years he has, and that can be you know, lived happily, so that can go on to relieve a lot of his problems. Next slide. So there is still further still researches going on in this field, and the main focus of research is now on harnessing the endogenous opioid systems. So if to rationalize this, the cells, especially the squamous cell carcinoma, these are basically keratinocytes. So keratinocytes are well known to produce a lot amount of the endorphins, the endogenic opioids. But these keratinocytes, they hold the endogenous opioids inside themselves. So once the receptors, there are certain receptors, like for example, endothelin B receptors or cannabinoid receptors. If these are activated, these endorphins, they get released from the keratinocytes, and they improve the pain. So these things are the research is going on in these fields. Then there is also a concept of opioid gene delivery. So herpes simplex virus is a double-stranded DNA virus. So what is done is this opioid gene is spliced onto its DNA virus and injected intradermally, and via retrodromic transmission, the herpes simplex virus, it reaches the dorsal root ganglion, stays there, and it produces the endogenous opioids. So these are still in the research phase. We have not yet, they have not yet come into the market. Then also there is research going on in the field of, next slide please, monoclonal or antibodies against certain particular receptors, like this protease activated receptors. So basically what happens is the series protease which are elaborated by the cancer cells, they cleave the protease activated receptors, and these bind to the certain receptors uh, which activate the action in the neurons. So that is the mechanism by which it leads to hyperalgesia and mechanical allodynia. So if you have antibodies to these receptors, they can play a role in controlling the pain. Similar is the case with the nerve growth factor, as I had pointed out earlier, that they are neurotropic, they lead to neurotropism of the tumor cells. So once you have an antibody against them, not only the pain perception will decrease, but even there is a possibility that the tumor aggression will decrease in such a certain case, in these cases. So this was in short about the management, the mechanism and management of the orofacial cancer pain. And if you have any further questions, I would like to take them. Thank you.
Thank you, Dr. Ashish. Considering that oral cancers are the most commonest cancer in our population, oral cancer pain management is absolutely essential. Obviously, we are going to work in close conjunction with the oncologist and the other supportive staff. Yes. So in terms of pharmacology, in managing these patients, obviously the pattern is going to be different. And there is also the factors where, because it's a closed cavity and the pressure effects intracranially can cause a lot of pain, some of the blocks don't work that well. So in terms of pharmacology, what would be your approach?
See, basically, most of the time it would be the perineural invasion is the most important cause that leads to these types of facial pains. So in addition to opioids, because most of the time whenever the patient has come to me, the oncologist has already started the patient on opioids, and the patient says that he is not doing too well, or the patient is not very happy with the side effects of the opioids. So my next step would be to go on to neuropathic medications, like use of antidepressants or maybe use of anti-epileptics. I usually love to start the patient on anti-epileptics first. Usually I would start the patient on carbamazepine or valproate. And if the most of the time the patient does respond, maybe if the patient is responding partially, then I would want to go over to antidepressants. And in that case, I would want here I would want to add on the tricyclic antidepressants along with gabapentin. So usually it has been seen that gabapentin alone vis-a-vis gabapentin along with tricyclic antidepressants, the latter seems to work better. So in addition to the anti-epileptics, it would be a combination of the anti-epileptic as in gabapentin and a combination of the tricyclic antidepressants. And some patients do well with even clonidine. And if the patient is not having too much of an issue, like the patient is not asthenic, or the patient is not, I realize that the patient does not have so much of the nutritional status is good enough to withstand the adverse effects of clonidine, I can add on to that in conjunction with the other medications. So that would be the step one of my process of starting the treatment process. Then later on, depending upon what all the patients is having, like for example, if the patient is also having, bony metastasis, I think about referring the patient for radiotherapy, or maybe adding on some radionuclides. Usually I don't. Yeah.
Right, and also we find that the interventions don't work that well in oral cancers. Is there anything you can throw light on?
Yeah, you know, sometimes, though, despite knowing that the intervention may not work, you would want to rule out three things first. First thing, you would want to see whether there is any other reason for the pain occurring, because it may be myofascial pain, or maybe some the patient has some problem associated with the TMJ of maybe because of the surgery also. Also, there can be a possibility that the tumor infiltration of the nerve has become so bad that no matter what you do, it doesn't affect, especially the peripheral nerve lesioning. So you may have to go for something deeper, as for example, you can go in for radiofrequency ablation of the trigeminal ganglion. And even if it doesn't, if that doesn't help, maybe you can go in for balloon compression, because that goes even more closer to the root zone. And third thing that you must anticipate is that there is a high possibility of the CRPS associated with such patients. So you may have to shift your focus from the facial to the stellate ganglion.
And you use oral steroids in treating cancer pain?
Oral steroids, yeah, definitely, because there are two mechanisms of action of oral steroids. One is because it may serve to decrease the perineural edema, which is because of the infiltration. Secondly, it can also decrease the inflammatory effects of the mediators, which are secreted by the tumors. So definitely, the oral steroids can also add on to the benefits.
Yeah, there is a question about local delivery systems. So people want to know if you can use any goggles, local application for oral cancer pain.
Yeah. See, whatever conjunction or whatever adjuvants you want to add, definitely you should go all out and add. But then you cannot expect miracles to occur with local goggles or local anesthetics. So when you do a gargling or something, only the superficial layer, maybe the superficial nerve endings are taken care of. But just imagine that the tumor has infiltrated perineural. Chemicals which are secreted by the tumor cells, those things also have to be taken care of. So maybe the patient may say that I have had maybe say around 10% of relief with local goggles, but not much.
Okay, here is a question from Dr. Rajiv Harshe. Patient has had left-sided hemimandibulectomy, having right-sided neuralgic facial pain. No cervical symptoms. Left-sided hemimandibulectomy, right-sided neuralgic pain. So he wants to know how you'll go about it.
Actually, I have had a patient 1 month back with the same problem. The patient on PET scan showed that it was the left-sided nerve which was getting affected, and the patient had significant problem on the right side. So initially, I was surprised by why. And the patient not only had trigeminal neuralgia, the patient was also having glossopharyngeal neuralgia in this case. So definitely, one thought is that maybe the tumor has, from the last PET scan, the tumor has progressed so much that it has gone on to involve the right side. But there is also a possibility, which we have already discussed, that the patient has these inflammatory mediators which are affecting those nerves. So you can, for this patient, what I did was I first gave a local anesthetic block just at the entry of the foramen ovale and at the glossopharyngeal, and the patient had significant relief, which the patient came after around a week or so, saying that the first 5 days were absolutely quite very comfortable for her. So based upon this, I ended up doing the radiofrequency lesioning at the trigeminal and alcohol neurolysis of the glossopharyngeal. The patient has done quite very well within this 1 month.
Right.
So definitely, what I am opining is that if you are planning any intervention, first you try giving a block with a local anesthetic and see how's the response. If that response is good, maybe you can very well go ahead and try it out.
Right. Thank you, Dr. Ashish. Any of the audience have any doubts for any of our 6 speakers? You can put it up in the comment column and we'll try to ask the speakers to clarify that. Any doubts for any of the 6 speakers?
There is one question about a volume of neurolytic agents in glossopharyngeal neuralgia.
Okay. So usually
Dr. Ashish, 1 second. Is Dr. Jitendra Jain here? Right, Ashish, you take the question.
Hello? Okay. So basically, what I do is I touch the styloid process, slip 0.5 centimeter beyond the styloid process, see that there is no blood flow through the needle, give the dye to confirm that there is no vascular spread. After that, you just give 0.5 ml of the local anesthetic and you assess whether the patient has got significant amount of pain relief. If the patient has got significant amount of pain relief with 0.5 ml of local anesthetic, you just limit your neurolytic agent to 0.5 ml. Yes, definitely the neurolytic percentage that I use around 75% of alcohol.
Right. Just to add on to
usually any neurolytic procedure, if you're doing, the amount of neurolytic, the volume of neurolytic that you would inject would be same as your local anesthetic, because you just want to cover that one. You don't exceed the volume because you would be catching unnecessarily areas which you might be not noticing when you're doing the local anesthetic block.
Sure.
So this is a very important thing that one has to remember before doing any neurolytic block or increasing the volume unnecessarily. And it's a very critical area. You want to avoid vagus. So the only way you can do it is by minimizing the volume. 0.5, as Ashish has said, is perfectly acceptable.
Wherever possible, I think use RF.
Yeah.
Correct.
This
yeah, that is true, sir. RF is definitely a good option, but we have to realize that if it is a cancerous lesion, then there is always possibility of missing the nerve in RF, because the localization, I mean, it may get distorted, the anatomy may get distorted. So if you have something which can spread on, I mean, to involve the little, you know, in which accuracy is not very.
The reason why patients don't respond is because there is more than one nerve which is involved. That is one of the reasons why most of the patients with onco do not do that well with neurolytic procedures. So
there is one question for Dr. Preeti. Madam, role of spinoparietal ganglion neurolysis in refractory trigeminal neuralgia, V3 dissolution.
You can also add role of stellate ganglion block here.
Yeah. So neuropathic pain involving face definitely we can consider a sympathetic block in form of stellate ganglion block. That's a simpler technique, more accessible. If the patient does not respond to that, yes, sphenopalatine ganglion block has been shown to give relief if the patient with trigeminal neuralgia doesn't respond to a trigeminal RF thermocoagulation. And the other thing which is now coming into practice is a stimulation of sphenopalatine ganglion, again for intractable patients with trigeminal neuralgia pain. So that is a possible option if the patient can afford and the patient accepts the therapy.
In fact, for the SPG, it is mentioned in the like in a lot of recommendations is there that in any facial pain with the resistant cases of the facial pain, you can go ahead with this spinoparietal ganglion neurolysis, and studies have shown good results in the resistant cases also.
Sir, actually, the sphenopalatine ganglion, because there is a lot of interplay of the parasympathetic as well as sympathetic, some amount of sympathetic input is also there. So in case you have, I mean, the somatic nerves not effectively taking up, definitely if you interfere with this interplay by doing a sphenopalatine ganglion, it does improve the outcome. Yes.
It's true. So any chance of prolonged battery? Dr. Raju Harsh is asking, with alcohol neurolysis of glossopharyngeal, is there any chance of prolonged bradycardia?
With glossopharyngeal neurolysis?
Yeah. is there any chance of prolonged bradycardia?
Quite very unlikely, because see, here what you are doing is you are not stimulating the vagus nerve, you are basically ablating the vagus nerve. So there is I have not seen any cases of prolonged bradycardia with neurolysis of glossopharyngeal nerve. Sir can share his experience.
Never seen.
Another point is bradycardia is more likely with a right-sided glossopharyngeal block as compared to the left side, because the right vagus nerve supplies the SA node, and that is why those patients could get more likelihood of bradycardia.
Ma'am, if you are stimulating, there is always a possibility that the vagus stimulation is leading to, but if you are neuralizing, it is quite very unlikely that it will cause prolonged bradycardia.
But there could be irritation or inflammation initially when you inject a neurolytic, and if it spills over to your vagus nerve.
There's a possibility, yes.
But whether it can cause prolonged, I'm not very sure.
Yeah, never seen. I don't think anybody has seen such case.
No,
only if you're a bit cautious in terms of the volume that you inject. If you not if you not increase the volume, and your diagnostic block has been relatively safe, I think it's perfectly acceptable to get whatever result. I mean, I haven't experienced much with alcohol neurolysis, but with RF, I haven't seen any of this.
I think Karthik, we are over time now. 30 minutes. You can wind up this.
Yes. Thank you to the ISSP, the President, Kothari sir, Secretary, Pankaj. Thank you to all the speakers. So I remember you didn't have much time, so we were pretty much told about the topic only on Friday evening. So pretty much all the speakers did well and came up with a fantastic show. So thanks to all of you. So I'm sure whoever attended, I think at one point we hit about 240, 250 delegates who attended online. So I'm sure we will not be able to cover all the doubts, but we tried to do justice in whatever time we had. So thank you one and all. So good show to all the speakers.
Happy Akshaya Tritiya to everyone.
Thank you.
Today's
Same to
auspicious
you.
day.
Thank you. Be safe.
Yeah.
We come out of the lockdown very soon.
Yes. Stay
Thank
safe,
you.
everyone. Stay
Okay,
safe.
for all the audiences, this is another information is that we have this SIG we have recently formed, and Dr. Pratibha Machi, she is coordinating this SIG, and all the panelists are there in the SIG members.
On orofacial pain.
On orofacial pain. So very soon we'll have this our own guidelines on orofacial pain. So this SIG is working on that. That's one information. And thank all of you, all the participants, all the speakers, the moderator, and our president. I thank all of you. It was a wonderful show. So I'll just ask our president to please give his closing remarks, please. Thank you.
Well, thank you everyone, and it was excellent presentation by each speaker and panelist, and excellent questions and inputs from our audience. That is very important, because we are getting so good response from our audience that we are eager to do more such webinars. Though we are getting a lot of WhatsApp that cause of death is now going to be more of webinars rather than COVID. But I think people are enjoying it. So Pankaj, we should do more. I think this is the right time. And with that, I think we can close the session. Thank you very much, everyone.
Thank you so much.
Thank you.
Sunday we have this neuropathic pain. Next Sunday is neuropathic pain.
All right. Yeah.
Thanks.
Bye.
Thank you. Bye.
Thanks everybody. सर बॉम्बे में तो कंपलसरी कर दिया प्रैक्टिस करना.
हाँ. So basically, hospital-based practice is what we are thinking of starting.
No, but
not many patients. Patients are also very. They are not coming forward to.
No, but BMC has